This little video is something I'd like you just to remember going forward. I don't expect you to act like this, but if you do, invite me. And it's really amusing, so let's watch it.
If you've learned a lot about leadership and making a movement, then let's watch a movement happen start to finish in under 3 minutes and dissect some lessons. First, of course, a leader needs the guts to stand alone and look ridiculous. But what he's doing is so simple, it's almost instructional. This is key. You must be easy to follow. Now here comes the first follower with a crucial role. He publicly shows everyone else how to follow. Notice how the leader embraces him as an equal. So it's not about the leader anymore. It's about them, plural. Notice how he's calling to his friends to join in. So it takes guts to be a first follower. You stand out and you brave ridicule yourself. Being a first follower is an underappreciated form of leadership. The first follower transforms a lone nut into a leader. If the leader is the flint, the first follower is the spark that really makes the fire. Now here's the second follower. This is a turning point. It's proof the first has done well. Now it's not a lone nut and it's not two nuts. 3 is a crowd and a crowd is news. A movement must be public. Make sure outsiders see more than just the leader. Everyone needs to see the followers because new followers emulate followers, not the leader. Now here come 2 more people, then 3 more immediately. Now we've got momentum. This is the tipping point, and now we have a movement. As more people jump in, it's no longer risky. If they were on the fence before, there's no reason not to join in now. They won't stand out, they won't be ridiculed, and they will be part of the in crowd if they hurry. And over the next minute, you'll see the rest who prefer to stay part of the crowd, because eventually they'd be ridiculed for not joining. And ladies and gentlemen, that is how a movement is made. So let's recap what we've learned. If you are a version of the shirtless dancing guy, all alone, remember the importance of nurturing your first few followers as equals, making everything clearly about the movement, not you. Be public, be easy to follow. But the biggest lesson here, did you catch it? Leadership is over-glorified. Yes, it started with the shirtless guy, and he'll get all the credit, but you saw what really happened. It was the first follower that transformed a lone nut into a leader. There's no movement without the first follower. See, we're told that we all need to be leaders, but that would be really ineffective. The best way to make a movement, if you really care, is to courageously follow and show others how to follow. When you find a lone nut doing something great, have the guts to be the first person to stand up and join in.
So I'm happy to be called a nut. I'm more than happy to be called a nut. I'll be a lone nut. We won't talk about my theory on almond milk and nut juice. But I would encourage you all to be a follower. Chronic disease management is not sexy. It's not, it doesn't gather a lot of attention, but it affects so many Australians of all different colours and creeds. But I would encourage you all to become followers, hop on board, because the sense of satisfaction and the sense of achievement that you can get by helping people with a chronic disease can make a huge impact on their life. Chronic disease management, learning objectives. I've got to do those first because you've got to know what I'm going to tell you. I'm going to tell you why is chronic disease important. I'm going to say what things you can do to help manage chronic disease, and then how you get paid to manage chronic disease. Pretty much sums it up, yeah? And getting paid means eating, so we're all in favour of that because we just did. Chronic disease affects a huge number of people, as I said before, 11 million. 11 million. That's a truckload. That's a truckload of truckloads. Chronic diseases, 7 in 10 deaths are from chronic disease. But chronic disease is insidious. A lot of people with chronic diseases don't actually realise they have a chronic disease until it causes an impact on their life. Which is where you guys come in. by helping them realise the impacts that it can make and the real small subtle changes they can make, because you can't make them for them, to change the outcomes. A little bit passionate about chronic disease? Sorry, not sorry. What can we do? We can do an assessment that gives us real data, real knowledge about where the patient is at and what's influencing the patient. As I said before in the previous session, culture has an impact. Financial status has an impact. Social status has an impact. Whether you're socially active or not has an impact. Where you work has an impact. We're beginning to get the picture that a lot of things, i.e. everything, has an impact on chronic disease, which also means you as practice nurses or GP nurses or whatever term you want to use, primary care nurses, can have an impact in helping people manage their chronic disease. A lot of studies have shown us that if you make your care tailored to that person, so person-centred care, you can have a very big impact a lot more quickly because it's relevant. It means something to that person. I never do a diabetes care plan. I've done thousands and thousands. I can't even count how many care plans I've done in my lifetime. I've never done a diabetes care plan in my life. I've never met anyone called diabetes. I've done a care plan for Mavis, who has diabetes. I've done a care plan for Fred, who has diabetes. David, I can pick a name. I've probably done a care plan for them. And they may or may not have diabetes, but I've never done a diabetes care plan. Because there's no one called diabetes. Having a care plan centred around diabetes is missing a whole big chunk of a person's life and what impacts on their diabetes. Studies show us that patients with complex chronic diseases spend 1 day in a general practice in a year. Okay, they don't spend 1 day and then you don't see them again. They spend an hour here and an hour there, but it adds up to 1 day out of 365. That's not a lot of time. So there's a whole heap of other things, like 364 days, that are having an impact on their lifestyle, which is having an impact on their chronic disease. There's a few things you can do as a practice nurse to facilitate the assessment and then the care planning to impact on their chronic disease. And a lot of impact is made in planning out care so the patient knows what to expect and you know what to monitor. In general practice, I often say to my patients that we can monitor, we can support, and we can educate. Monitor with blood tests, ECGs, all sorts of tests, weights, heights, eye exams. We support with medication, a friendly hug, how you're going, a smile, a commiseration, empathy. Medication is support, doesn't change the chronic disease. We can educate, we can give them information that they can choose to use or not use to impact on their chronic disease. But any changes, anything that happens to actually change the course of their chronic disease has to be done by the patient. Because you can't go with them and hold their hand and force feed them their medication and force feed them their food and drag them around the block on a walk. That's frowned upon. Just saying. All you can do is support, educate and monitor, engaging the patient and promoting that motivation to do it themselves is what makes a difference for these patients and for all of us. The stats are showing that a lot of us are going to have a chronic disease in the future. So if you can plan out what care specific to that patient, it's much easier to get buy-in from the patient because they think you care. Now, if someone cares whether or not you go home tonight, you're more likely to want to get home. If there's no one at home and my friend rings me up and she says, come for a coffee or a drink of some description, there's no one at home, I'm thinking, why not? Because she cares. She wanted me to come for coffee. She wants to see me. And it's the same for the patients. If they think you care, and I encourage all my nurses, all the nurses that I come across, doctors I don't care, to care between the hours of 9 and 5 with half hour off for lunch. particularly in general practice, then if the patient thinks you care, they're more likely to want to have a change. They're more likely to want to come back and tell you where they've succeeded. And to be able to tell you where they've succeeded, they've got to have succeeded. So that's where you get that motivation for the behaviour change that the patient has to carry out. There's a few tools I have for supporting that care planning, and I'm more than happy to share them. There's one that we call a pre-visit checklist, and I have a copy of it here somewhere. Here it is, under here. For any care plans that are done in the practices that I work in, this has been PHM branded for something that I'll share with you later. We had a version of this, it's called a pre-visit checklist. And basically it says the things that I thought were important, because you can't really do a care plan in under 30 minutes. Meeting just the Medicare requirements, which I'm going to go through, to do a care plan in under 30 minutes is a pretty mean task. And again, as I said before, if you guys find a way to do it, can you let me know? Because I'll learn from you. I've been doing care planning for a fair amount of time. We used to do care planning back in New Zealand in the 90s. It came over to Australia a bit after then. And I haven't figured out a way to do it, particularly a way to meet the MBS requirements. This care plan actually says, this pre-planning checklist actually says, do you have the appropriate time for the visit and what you're trying to achieve? It's a checklist. Yes, I do. I've only got 10 minutes. Probably not going to happen. I could start it, but the whole thing's not going to be completed in that 10 minutes. If you are, you're not meeting the Medicare requirements. You're not going to get patient engagement in 10 minutes. You're not going to do a comprehensive assessment as part of your care planning. You can't plan care if you don't know what you're caring for in 10 minutes. You can't get patient engagement, that patient want to change things in 10 minutes. Have you followed up on previous results? They're probably important to monitoring and knowing where your starting point is, when you might want to check them again. Because if they've been checked 6 months ago, checking them again in 6 months is a yearly test, and a lot of the chronic diseases have that in the guidelines, yearly cholesterol, 6 monthly cholesterol, those sorts of things. Is there any correspondence from other people that you need to include in the care planning? You know, is there a specialist who wants to see them again in 3 months' time? It's part of care planning to allow for that. Have you checked what referrals, what scripts, what screening that patient is due? Preventative care goes a long way to helping chronic diseases not become worse. Their My Health record, is it up to date? Does it have their latest list of chronic diseases, their latest medications on there? Because the My Health record, and they're going to be used more and more by the hospitals, and they are already starting to be used quite regularly by the hospitals. If they don't have a current medication list, the hospital's going to be ringing you, your practice, and the GP is going to be saying to you, print out a medication list for these patients, the hospital needs it. It's going to take up your time. If you've updated the My Health record, you can just say, tell them to look at the My Health record. Reception can answer that phone call, which means you don't get the interruptions when you're trying to do a health assessment. So there's that little bit of time management that goes into doing a care plan and chronic disease management. When you're planning for chronic disease management, have you gathered the education resources that might be helpful for these patients? I've got a patient coming in, has had COPD for a little while. We last updated their action plan 3 years ago. Having some information on action plans and how they can help might actually influence this patient to get them updated more regularly so they can actually be useful. So, chronic disease management requires an assessment. We've already talked about most of the things coming along with health assessments. Don't forget, time is needed to do a comprehensive assessment. And then managing the patient's expectations going forward. What are you going to do now that you've established that this patient has needs? How are you going to get that patient buy-in? Through education, through support? Is there any carers needed? Those sorts of things are all things you might want to consider with chronic disease management, because chronic disease requires more than just your input, and a lot of the time more than just your input plus your doctor's input. Questions yet? We doing all right? Cool. This particular slide talks about collaborative pathways, and that's developing relationships with specialists, the allied health professionals, or anyone who impacts on this patient's care. I've been known to be frowned upon for sending a care plan to a naturopath, and the practice was like, why? They don't get anything for it. But the naturopath actually had quite a good clinical relationship with the patient and was actually doing quite a lot of support for the patient. So letting the naturopath know what we were planning to do and what steps we were planning in the monitoring and support of this patient, I'm assuming probably helped the naturopath add to that and keep this patient on a positive journey. If I was a naturopath, I would have appreciated that, because it gives you a more view of the whole patient, not just the little bit that you're dealing with. So I convinced the GP, they thought it was a good idea. We got a lovely letter back from the naturopath, just saying. They thought it was a good idea too. So we've got our assessment, we know what we're dealing with, and then we're going to move on to what are we going to do now? How are we going to keep this patient wanting to have the best health outcomes? The patients have a role in these outcomes. We just monitor, support and educate. So there's 3 E's. Engage with the individual. They want you to care. They come to your practice, they want you to care. If you can show, you can remember that they went bowling or bowling, lawn bowling. People keep spelling it wrong, it just amuses me. If they know that if they know you are engaged with that patient, they'll become more engaged with you. You know their favourite activity is playing with their grandson on a Tuesday afternoon, and you say, "Hi, Mrs. Jones, how's your grandson? Was he well on Tuesday?" It's like, oh, this person's interested in me. Oh, that's a good thing. I now feel better about myself. I might want to do something more. So engaging with your patient, getting them to believe they're worthwhile enough to make the change is part of chronic disease management. They've also got to believe, part of engagement is them believing you know what you're saying is right. So you've got to do your homework, people. Don't forget to put it down in your CPD hours, because that's about your well-being. Education tailored to the patient's need. If I start talking to Mavis, who's come in, she engages with her little grandson on a Tuesday afternoon, and if I start talking to her about chasing her grandson around the block, her grandson's a marathon runner, it's never going to happen. It's got to be appropriate to your patient. I've had patients who the best they can do is get to their letterbox. Their letterbox being open the front door, down 3 steps, and take 4 steps outside the front door and they're there. That's the best they can do. And I'm telling them this is fantastic, because for them it actually is. It's quite an achievement. So I'm now going to ask, do they think they might actually be able to open the front door and walk down those steps twice in a day? Oh, I couldn't do that. I'm too tired after the first time. Okay, what do you think you can do? I might be able to walk to the front door. Excellent. This week, all I want you to do is get to the front door and back to your chair. If you can do that this week, next week we'll talk about opening the door and getting down the steps. For that patient, that's a big improvement. They're probably taking 10 more steps. That's, that's twice the number they were taking 2 weeks ago. For other patients, it's about tailoring it. Can you walk to the end of your block? Yeah, I can. Terrific. What if you can walk to the end of your block in 7 minutes as opposed to 10? Small achievable goals tailored to what your patient can actually do. Relevant to your patient. I hate running. You encouraging me to go to a gym and hop on a treadmill will never happen. But if you say, go for a walk around the block, probably I'll manage that. Walking around the blocks are really cool because I'm a bit nosy and I like to see what my neighbours are up to. That's tailoring it to me and what I'm interested in. doing things like that, engaging with your patient and finding out. They go to bowls. Can you walk to bowls? Well, it's only 2 houses down. I hadn't thought of that. Or even asking the patient what they can do. Or, here's an idea. Has anyone ever asked the patient what they actually want to achieve? So the patient's aims, what they want to achieve. A lot of them will say staying well. And I've watched this quite a number of times in a GP practice, in the care planning template that we use. It has patient aims. And so the GP will diligently fill in what the patient's aims is. Staying well. That's great. That really doesn't tell me a whole heap. What does well mean for that patient? Does well mean going to my daughter's wedding on Saturday? Next Saturday? Don't get that confused. That could end badly. Does well mean going to my daughter's wedding in Perth in 6 months' time? Does well mean being able to help my grandsons shift that pile of dirt next Saturday or next month, or to keep helping my grandchildren with whatever they need? It's finding out what that means to the patient, and sometimes that's an interesting conversation to have. You need longer than 10 minutes to be able to do this care planning that's patient-centred, that gets the patient. And then you've got to give the patient the knowledge. If they don't know what they can change and how to change it, they're stuck. If you overwhelm them with information, they're going to do nothing. As nurses, we're really, really good, and all of you will be too, of assessing, if I give this patient this much information, that's going to be enough for him. Sometimes we get it wrong. I'm really good at that. But next time you won't, because we all learn from our experiences, and so does the patient. So you might say to the patient 3 things, and I use different terminology and I only say 2 things. So long as you're tailoring that to the patient's level of experience, no one's wrong. But be mindful of it. Patients have different levels of knowledge and experience, and tailoring what you're teaching them to that level of knowledge and experience. So teaching an engineer about water pumps when you're talking about heart failure can actually be beneficial because it relates to something that they already know. Talking to a plumber about water pumps probably works as well. Talking to a mechanic about water pumps, and he'd be looking at you thinking, what are you talking about? But if you talk to him about engine valves, he'll get it. So tailoring your language when you're doing education to something that matters to the patient. That can be simple as the garden hose and a bucket, or whatever you can transform that information to be. Talking to people about heart failure really freaks them out, because when you say the car failed, the car don't go no more. But when we're talking about heart failure, the heart's still going. It's just not going as well as what it did. But a patient hears the word failure and they think, it's going to stop now. So tailoring your information to the patient's level of experience really makes a big difference. And then enabling informed decisions. It's not your job to decide whether I'm going to stop smoking or not. I don't actually smoke, but it's not your job. It's your job to give me the information tailored to my level of knowledge and experience, so that I can make that decision with information. So there's lots of patients that I've spoken to about smoking, there's lots of patients that I've spoken to about exercise, diet, managing their health, and they've chosen to continue doing what they were doing. That's great, because usually they're adults. I've given them the best information that I know, in the best way I know that's suitable to that patient, and they've made an informed decision to choose which way they go with it. And that's actually okay. So they're the 4 E's. I go into this because I didn't write these slides, so I sort of get a bit jumbled, but you'll bear with me. The information's the same whether I say it to which slide. So assessing the person's knowledge, and that's not too difficult. Have a conversation. Even talking to them about what they've done last Saturday can help you assess their level of knowledge and experience, so that you can tailor your information to meet theirs. If a patient doesn't want to talk about the fact that they smoke, Do we force them? Is that going to end well for any of us? Yeah, I agree, it's not. It tends to put the patients back up, and it tends to mean they shut down and they don't take in anything that you have to say, which defeats your purpose. So acknowledging the things that are just a bridge too far, acknowledging the places they are not ready to go, opening the door, and if they're not letting to go, leave it alone until they are. Individualise what you say, make it appropriate to that person. Encouraging their involvement. It's their body, it's their life. They probably should get to choose. Just a theory I have. But it's a theory that's based on sound knowledge and experience, and it's based on watching what patients do with information that I've given them. Go nuts, give it a bash. Use as many people, it doesn't say that, but this is my interpretation, educate the benefits of allied health professionals and others. Use as many people as you can to help influence the outcomes for the patient. If the patient is open to seeing someone else, encourage the patient to do that. Encourage the patient to use whatever resources, because it might be that the blonde-haired, blue-eyed ex-football player podiatrist can get through better than I can. End result is the patient stays weller, my word, which is what we're all trying to achieve anyway. That's our purpose. I encourage you to give written information. I, at this stage, am not a big fan of websites. For some patients, it's really, really appropriate. And this is just my personal experience. A lot of the patients we're dealing with are over 50, and their experience with information given to them on a screen isn't always as much as ours, and they don't take it in my experience as well. Or you'll say, go look up this website. And they've got an iPad that their grandson gave them for Christmas, and they're quite happy playing their card games, looking up Mr. Google for information on where to buy socks, or JB Hi-Fi websites, or whatever, or what's on at the club on Saturday night. But to look up health information and take it in and understand it is sometimes a little bit more difficult. So I would encourage you to consider, again, that patient and what is involved in that patient's literacy to when you're imparting information. And then if you are giving out websites, encouraging the patient to be discerning. We're looking for websites that have some credentials behind them rather than Dr. Google, which, as we all know, can lead to some very interesting discussions. I have a patient who had chronic heart disease, came in very, very excited one day, very, very excited. He'd had a heart attack on the weekend. He was wrapped because he knew what caused it. This particular patient, we'd spent a little bit of time convincing him that improving his diet would be a good idea to manage his chronic heart disease. And he did improve his diet because he added coleslaw to his KFC order on a Thursday. Exactly what I said, better than before. He was a lovely, lovely man. He probably still is. I actually don't have any contact with him anymore. But he was wrapped that he'd had this heart attack because he knew what caused it. He got his McDonald's, he ate takeaway food every day. He worked in a factory. He got Subway for lunch after we'd had our discussion, because that was an improvement on the Chico rolls and chips that he used to get. Yeah. But on this particular weekend, he got his shake from McDonald's. Friday night was McDonald's shake and KFC. Saturday night was burger from the local burger joint. He got his shake before he got his KFC. And he drank it because he was thirsty. He'd been out in the sun playing with his daughter and his grandson. And he had his shake because he was thirsty before he had his KFC. He went home and he had a heart attack. And he called the ambulance and they came and they rescued him and he got taken off to hospital and then discharged himself because he felt he was too well to stay. And he came, did what they said. They said, go and see your GP on Tuesday morning, long weekend. So he did, he came in. So I was absolutely ecstatic because he knew what caused. And I said to him, you don't think there's a problem with what you're eating? You don't think that had anything to do? He said, no, because it wouldn't, if the government said it was wrong for me, they wouldn't let them sell it. if it was going to be bad for him, the government wouldn't let them sell it. So this dude had it all sorted out in his head, and he was a really genuinely nice gentleman. He just had a completely unusual view of what was healthy and what wasn't healthy. And he really believed that if it wasn't going to be healthy, they wouldn't be allowed to sell it. So people's health literacy and what's available information to them can really influence the decisions that they make. So from that, I would highly recommend that you screen what information or what websites you're sending your patients to, rather than letting them go mad on Dr. Google and come in with all sorts of weird and wonderful diseases that no one's ever heard of.
It's a government conspiracy. They're telling us it's all okay, but I'm not going to believe it.
Yeah, well, maybe he should have not quite believed the government's dependence on big business, but they wouldn't have been allowed to sell it if it was bad for you, so, you know. Person-centred stuff, and again, I've skipped around a little bit, but person-centred care has been quite well documented all across the world to be the way of engaging patients in their own chronic disease management. Remembering that we're advising, supporting and monitoring, it's them that have to make their changes. The things that are involved in person-centred care include, but are not limited to, the way you communicate with patients, the motivation that you can elicit from patients. And there's lots of courses out there on motivational interviewing and various versions, and I encourage you to start opening the door to yourself and having a look at that. It can make a big impact not only on how you communicate with your patients, it makes a huge amount of difference with how you communicate with your friends, relatives and children. Helping patients manage their chronic diseases using case management. So having a conference with those involved in the care of your patient, a bit of a huddle with the GPs and the other nurses who've been involved in the care can make a huge difference. And you will know that if you're doing wound care in a hospital, you'll all have a chat about, oh, this worked, that worked, something else worked. Just because you've now jumped out of the hospital and you hopped in a GP practice, which is just 4 walls that are just a bit smaller, doesn't mean you've lost those skills to communicate and learn from your colleagues, or they can learn from you. So I encourage you to use that case management strategy that we use by osmosis in a hospital to use it now in general practice. Have a chat in the tea room, have a chat in the corridor. Some places have formal huddles where they stand at the beginning of the day, all in the tea room or in the corridor or wherever, before the patients get there, and they'll say, anyone got any issues with their patients today? And you'll say, yeah, I've got so-and-so coming in for a care plan, but I really need you to impact on this. I've got so-and-so who's got a really bad wound and we're not getting anywhere with it. What should we do? I've just done an assessment on Mavis and she probably needs an advanced care directive. She's coming in today. Can you broach that subject with her? Little things like that can make a huge impact on the overall care that your patient gets when they come into the clinic, which impacts on outcomes. Making it centred around what the patient actually needs means the outcomes are tailored to the patient, which means the patients think you care, which means they might want to do more. Oh, there's an idea. Get even weller. I get to use my word again. Oh, where'd it go? Oh, there it is. So all of those things, the patient's beliefs, the patient's engagement, they say having a sympathetic presence, which is a term I don't really like, but it's a presence that's engaged, it's a presence that's interested in that patient. Makes a big difference to the patient and what they want to achieve out of it. And there's a few patients, you'd be surprised to learn, there's actually some patients that I don't get on with that well, because I'm shy. And sometimes, stop laughing. Some patients sometimes find that a little bit confronting. Who knew? But I got really good engagement with them by being aware that that was something for them, and them thinking that our receptionist, who always asked about the dog and always asked about their neighbour, they thought the whole clinic cared because the receptionist actually connected with this particular patient that I'm thinking of. I didn't, but I was also responsible for care planning and monitoring and supporting that patient. But because I had buy-in from someone else, and they said, oh, Mary knows what she's doing, the patient trusted the receptionist. The receptionist could have said, tomorrow you're going to the moon, and the patient would have said, do I have to pack? The receptionist said, oh, you see, Mary, she knows what she's talking about, and I bought her chocolate. The patient would then sit and listen to me. So use whatever patient engagement strategies you can based around that particular patient. Because it meant the patient listened to me, which meant we were able to support that patient in achieving what they wanted to achieve to stay well. And that's what it is for chronic disease management, supporting the patient in achieving what they want to achieve. Usually they want to stay well. There's not that many who don't. Don't forget, when you're talking about chronic diseases, mental health is a chronic disease. Oh, this is a really weird slide. Mental health is a chronic disease. A lot of people with mental health diseases also have comorbidities that impact both on their mental health and on their lifestyle and living conditions, their social engagement, their financial support. And so don't forget to consider that when you are doing any care planning for any of your patients, but particularly those with chronic disease, particularly those with mental health illnesses. Oh, look at that, the slides caught up with me. It's a big push of mine to just include mental health without its own little heading. So you've got chronic disease and then you've got mental health standing over here beside it. I came back, it's all good. It's a big push of mine to include them both in one basket. Because just because a disease affects your feet and you don't have sensation in your feet anymore, makes it no different in the impacts it has on your life to the condition that affects your brain. It's still a chronic disease. It's something you need support and education and monitoring to change or to manage. So normalising it can go a long way to supporting your patients and achieving their own goals. Medicare and MBS. Medicare have strict rules around Medicare billing, and it's something a lot of GPs are a little bit wary of because they hear of doctors having to repay $1 million here and $10 million there, or whatever the number happens to be, because they've not looked at the Medicare billing requirements when they've been billing Medicare for chronic disease management items. And these are the big ticket items. They're the items that have a lot of money associated with them. So the doctors like them because they can make the clinic or themselves quite a substantial income. But also because they are the big ticket items, Medicare are strict about what the rules are. And that's probably fair because it's our money we're spending. We all pay our tax. It's quite amusing as nurses that we encourage doctors to bill Medicare so they can pay us so that we can pay Medicare. Sorry, weird mind. So, in every chronic disease management item number that you bill to Medicare, there is these requirements. The person involved must understand the steps involved, whether it's a mental health plan or a chronic disease management plan or a care plan or a TCA or a EPC or whatever acronym alphabet soup you want to use. It's all have the requirement that the person who you're doing it for must understand the steps involved. You must document that they have given consent. And that can be as simple as informed consent obtained in your medical records. But you need to document that the patient has consented. You need to get consent if you're doing a team care arrangement, or in the case of healthcare homes practices, doing shared care planning. You need to get consent that that care planning will be shared. And it should be shared. You need to advise the person, whether it's healthcare homes or non-healthcare homes under the traditional CDM management item numbers, what costs might be involved. Now, you can't predict what an external provider will charge a patient for chronic disease management. But by saying it's subsidised by Medicare, or by saying Medicare provide a certain amount of money, which is very easily documented, very easily found, I think it's $56 or whatever it is, $52, per allied health visit, and anything charged above that is at the discretion of the provider. So the physio, the podiatrist, the diabetes educator, the dietitian, all of those allied health providers can legally charge whatever they choose above the Medicare rebate item number, and the patient should be aware of that. I tend to say to patients that because we're going to try and help you care for your chronic disease, Medicare are going to provide $250-ish towards your health care. That's going to be paid to the provider. So if you are willing to come on board and help look after yourself. So as part of looking after yourself, we require this monitoring and you to come back for these reviews. And if you are happy to do that, then Medicare will provide an ongoing support for you, which gains their knowledge of what support's available. It helps them be informed about what steps they have to take to come back to the clinic so you can meet your MBS requirements. And it gives the patient some information going forward about what's going to be required of them. You know, we'll need a diabetes review at 4 months and 8 months, and we'll do a care plan review at 6 months, or whatever the time frame you've worked out in your clinic is appropriate for the care of that patient. The written plan must be offered to the patient. It doesn't matter what you're doing, on what format, under healthcare homes, non-healthcare homes, TCA, EPC, whatever. It must be offered to the patient. And it must be added to the patient's file. And those are the rules across the board. The other things you need to be aware of is you can't bill a standard GP consult item, so a 23, 36, etc., at the time of a chronic disease management item. You can claim if it's a mental health care plan, but not for chronic disease management. You can claim a mental health care plan at the same time you're doing a chronic disease care plan. And you can assist a nurse with a physical health care plan. The health care plan is time-based. The mental health care plan is time-based billing and is GP time only. And that's all in your slides, so hopefully if you've got any questions, yell, scream, send an owl, carry a pigeon. I'll try not to arrive on a broomstick. So, what is a GP management plan? Who's done a GP management plan? Who's done a GP management plan in less than 10 minutes? Go nuts if you have. I want to know how you did it still. And you may have done a GP management plan under the guidelines of your clinic, and it's not uncommon for clinics to insist you do them in 10 minutes. This is where you guys become a little bit of lone nuts out there, but you do have our support to say, actually, that's not meeting the Medicare requirements. Because these are the Medicare requirements. Patients' healthcare needs and health problems and relevant conditions must be recorded. You must do a comprehensive assessment, biopsychosocial. Isn't that a fantastic word? It's a good word for Scrabble. I don't think you get enough letters. Including cultural, including economic. You must agree on goals with the patient. You must let the patient know what you expect of them, what actions they're going to take. You must let people know what you're expecting of other people. So allied healthcare professionals, the naturopath, you must let them know what you expect of them and who's going to do it. You must get agreement from the patient when the review's going to be. Sounds like even just saying it's going to take longer than 10 minutes. Medicare recommend that you bill it every 2 years. Medicare also say that you must do a review before you bill a new care plan. So working out who's eligible, there's no age restriction. It's GP discretion. It's chronic illness or a terminal condition. So that's anything lasting 6 months or longer, or likely to last 6 months or longer. It must be developed with consultation with the patient. So if you expect to do a care plan without the patient being present, I hope you're able to answer how had the consultation with the patient. Any questions about GP management plans? So we move on to team care arrangements. And a lot of practices, team care arrangement is really similar to a care plan. You can actually combine them on the one sheet of paper if you need to. It needs to be very clearly documented that that's what you've done. The additional steps must include what you expect of the GP, of the allied health providers and you must get buy-in from those other health providers. There should be two-way communication. Lots of forms of two-way communication that's not specified can take, but there must be two-way communication. It's again supposed to be patient-centred. So doing a generic diabetes care plan for Mr. Diabetes, I'm not going to cut it. It's supposed to be specific for every patient. A nurse can be used as a provider on a team care arrangement if the nurse is providing services that the GP cannot provide. One of my qualifications is an asthma educator. If I have a patient with asthma, I can use myself on a care plan, or a doctor can use me on a care plan if I'm providing asthma education for the patient. They can't use me if I'm just doing a health assessment for that patient. Any questions about that one? So you must provide. Another thing that I have a skill in is weight counselling, weight control counselling. That's another thing that you can be used for on a care plan if the doctor's not providing that. Yeah? Any questions? No? You're all good? Excellent. Terrific. The time frames, it's recommended that you provide a time frame for this for team care arrangements to happen in. You use SMART goals, so goals that are specific, goals that are measurable, goals that are realistic, all those sorts of things. And the patient should agree to the goals. There's no point in having, if you don't have that patient agreement, chances are achieving that goal is going to be pretty out there. No questions? We're all good? Cool. When you're referring to the allied health professionals, you should include the reason and what you expect of the allied health professional. And that's where the two-way communication comes in. If the allied health professional says, well, actually that's outside my scope, that they are entitled to say that. So you need to explicitly explain what you're expecting of the allied health professional. Reviewing a team care arrangement, a 732, they can both be done on the same day. It must review the entire care plan, so you can't just review the diabetes bit, you've got to review the others. I recommend you put on care plans and care plans review advanced care planning or advanced care directives if you have them, or the decision maker with the new requirements from the Medical Treatment Act. It's really going to become more and more important that decision maker for the person is documented. And reviewing that at a care plan is a really good opportunity to make sure that, you know, I had my neighbour listed as my decision maker and my neighbour passed away last Tuesday. It's going to make it really difficult to consult unless you bring your Ouija board. So updating that information as regularly as you see the patient can actually have benefits to the patient and their care. In the care plans that I used to do, we always included hobbies, next of kin, because sometimes they change, they move away, they die, they have an argument, whatever. Including advanced care directive. Not that whether they have one or not, that's valid, but also have you had the conversation with them? Have you said to the patient, do you know this is a thing? Anyone can get hit by a bus. You don't always pass away if you get hit by a bus. Sometimes you just get injured, and there might be decisions that need to be made on your behalf because you're unconscious, and if you can't make that decision, who knows what your wishes would be to make that decision for you, remembering that you've got to live with the consequences of their decision. It's a thing people forget when you're talking about advanced care planning. It's not just about end-of-life care, it's about making medical decisions when you're not able to make a decision for yourself. Back to care planning. Don't forget to set a review date. When I see a patient for a care plan, I have a little thing, and this is one I adapted from a patient, was actually a real patient. And down the bottom, it's got this section where we have appointments, what appointments have been made. I'll put in that they have an appointment in 6 months' time for a review. So the patient knows what to expect. Outlined here is the sort of care they're going to get. This particular patient had COPD and anxiety and depression. And so it says I'm going to contact them in February. They're going to get a phone call. Did they actually understand what we talked about in the care plan appointment? And if they've got any questions, you know, this particular patient having COPD always got an action plan. And most of my patients got action plans, and I bought some of the Nelly ones that the PHN but most of these are based on action plans that I used to use in general practice. This one's about blood pressure, there's one about mood, there's diabetes action plans, and I used to make them up. I had physical activity action plans, eating action plans, you know, go to the fridge, am I really hungry? What am I going to eat if I am really hungry? If I'm not hungry, am I still going to eat? And just helping that decision-making process so the patients can make informed decisions. You know, how COPD action plans really common and really useful for helping the patient make those decisions. And those sorts of things go a long way to getting the patient engagement and encouraging self-management. And as I've said all the way along, it's the self-management that makes the difference to the patient care. We monitor, we support, we educate. They manage, they make the changes. So this particular patient has got, you know, attend a flu clinic for a flu vaccine, ECG in April. So the patient then has an idea of what I'm expected of them. No one can say I didn't get the patient agreement because they've taken this home with them. They've seen it. I've written down their goals on it and when the reviews are going to be. I used to have patients ringing me. It's the end of April and you said you were going to contact me in mid-April about such and such. You can't tell me that's not patient engagement. Sometimes it's a pain, but it is definitely patient engagement. Sometimes you get busy and you don't get back to them. But they know and they tell me. So, contributing to do any practices contribute to care plans for patients in residential aged care facilities? No? You do? Yep. The doctor does, yeah, well that's what I mean. As a nurse, do you review the care plans for the doctor? It is a role you can perform, reviewing the care plan.
The nursing home's care plan.
Yep, yep. You know,
so as in do the reviewing and then...
Yeah, or prepare the care plan for the doctor. The doctor says, yes, this is what I actually want for this patient. You collaborate with the aged care facility.
Different, because I've just been thinking like, so they do a health assessment, particularly for aged care residents. Yeah.
It's different.
Yeah, because obviously in the CMA, you have like a summary of the findings and recommendations.
Mm-hmm.
So how is that different to developing a care plan?
The summary of the findings and recommendations from a CMA will be we've discovered that this person now has heart failure and a wound ulcer on their leg. We recommend they receive treatment for such a thing. You do a care plan and that outlines what that treatment might look like.
So you might say, this person has diabetes, and then the care plan will say, this is how we're going to
manage it. Exactly, yeah. So the recommendation might be a care plan to monitor and support the diabetes management.
So how is that different from I think we've interpreted, because the aged care facility has their own care plans, obviously.
Yes.
How is that different to, and you can't claim
both.
What's the other number for
a 731.
A 731 or 7, yeah.
You can't claim a 731 and a 723. Yeah, that's correct. That's right. That's right, because they get paid through a different bucket of money for the allied health, the team care arrangement part of it. So essentially, 731 is the team. The doctor's part of the care team for when the patient is a resident of an aged care facility. So it's sort of like doing the doctor plans or participates in the planning of care in conjunction with the aged care facility, so they're not actually engaging the allied health as such. The aged care facility are engaging the allied health or whatever's necessary for their patient.
Yeah. So how's the contribution? We've interpreted that as, you know, the doctor reviews the aged care facilities care plan.
Exactly.
You know what I mean?
That's exactly right.
Yeah.
The doctor reviews the aged care plan, the aged care facility care plan, and says, yes, that's appropriate care for this patient who has X, Y, and Z diseases. And the aged care facility engage any allied health, even if it's recommended by the doctor, the aged care facility still engage any. The doctor's not engaging that, the aged care facility is engaging. That's why the team care arrangement's not valid.
You're saying that I could do that?
You can do the contribution and the preparation. The doctor does the, sorry?
The doctor signs off.
The doctor says, yes, this is actually the care we want to provide for this patient. Yeah, the doctor signs off.
So the aged care, they make the care plan.
Mm.
Yeah.
They, well, in most cases they do, not all cases.
And the
Yeah.
contribution would be in relation to a specific chronic health condition?
Well, it's still holistic patient care. It's still whole of person-centered care, whole of person care. So whatever you provide or the GP provides should still be holistic. So they're not they're signing off on the medical part as well as the overall. Yes, this is all about the whole person, because you can't do a care plan without encompassing. We've just explained that.
I'm just doing, so this, I'm getting a bit confused about the 731, the contribution to the
Care plan,
overall
yep.
aged care, the facilities care plan. The 731 is our contribution
Yep.
to that.
Yep.
So that is, I'm just wondering, in that contribution, what is our contribution to that?
Well, it will
Is
be,
my contribution to that?
have they recommended appropriate care?
Validation.
It's,
So
yeah,
reviewing
Money
the-
for jam.
it's validation that what the aged care facility are providing
Yeah.
is appropriate care for a person with those conditions.
Making sure they're making the considered
Does the doctor actually go to the aged care facility
Usually,
and they cannot, so are they allowed to just be at the practice and the person sees them at the practice?
to be honest, I can't answer that question because every time I've been involved with contributions to the residential aged care facility care plans, the doctor has gone to the practice. But I can find out and let you know.
The other thing is, can you for a patient like that bill a 721, 723 and then a 731?
No. No. It's either. Because they're either under the care of the aged care facility or they're under the GP care. No more? Cool. 10997s. Who uses 10997s? Yay!
That whole $12
$60?
over time, over the year,
Yeah.
but we do most of the care.
I know. I'm not.
It was raised before.
I'm not saying we don't do a good proportion of the care at all. Not at all. But it's better than nothing.
It's a bottle of Christmas party.
Yeah. it's a reward at the Christmas party, definitely. It does seem like an injustice. It seems like a token. It does. Remembering that the practices do get the PNIP to support employing a practice nurse, which is not an insurmountable bucket of money. The maximum PNIP that you can get is $125,000. $125,000 a year. Find me a nurse that costs that much because I'm going to work there. I know. It works out on swipes, and it does. It is a big practice that gets that kind of money. I'm not disagreeing with you there. It's again not a huge amount of money, but it does go a way to supporting what you do in general practice. I'm not saying it covers everything. I'm really not saying that, but it does go away to supporting that. So using that, you can use it for ongoing monitoring, engagement, screening, Would encourage you to all look at how many 10997s have been billed in the last 12 months in your practice and challenge yourself, can we increase that billing? Because if you can improve the business bottom line, chances are you can make a case to improving your bottom line, which means you get to eat better food.
So it's 5 per patient.
5 per patient per calendar year, yep. Case conferencing, are we all using case conferencing? Case conferencing is another item number that's valid to be used and quite beneficial to be used for chronic disease management. There are again specific requirements. The patient does not have to be present. You can have a case conference organised in the clinic by you. It needs to be recorded in the patient notes. You can have your podiatrist and your physiotherapy, yourself and the doctor there, and bill a case conferencing item number.
Sorry, what is this? What is
This is called case conferencing. It is basically identifying and outlining treatment needs or treatment plans for patients who have complex care needs or chronic diseases.
And this can be done by a nurse?
Can be organised by a nurse. There needs to be a GP present. It's billed under a GP.
Lining everybody up at the right time.
It is tricky to line people up at the right
Can I
time.
just ask one quick question? So we do these all the time, but another doctor in our practice has said that the doctor that I do them with shouldn't be doing them with me there.
Why?
So we do them with, I don't know, because I've read the Medicare stuff, and it says that from the way I read it is as long as the doctor, the nurse, and an allied health person or another health professional or a specialist or whatever is there, that's okay.
That is okay.
So there's
Yes,
no specific.
it is okay.
It's all based on time.
It's time-based. Needs to be 3 people present involved in the care of the patient. So it can be a GP, a nurse, and another health professional.
This can't be over the phone, can it?
Yeah, we do all over the phone.
But everyone can't be over the phone, but there can be a phone-in participant. Yeah.
Like allied health or not?
Yeah.
Yeah.
Yeah. Yeah. I believe so, yeah. I've not read that you can't, so I'm very confident that you can.
Rural areas have to do that.
Exactly.
We don't have everybody around the corner.
Yeah, exactly. So,
We do use that on a number of quite a bit. And it's very useful for patients' care.
Yeah, we use more.
Also apply for mental health care plans?
I don't know, to be honest with you. Let me check and get back to you. More than happy to get back to you.
I think mental health has to be the GP, I don't think it can't be the nurses.
It has to be a GP, but it has to be,
You could be in there to listen, but you can't be.
unless you're a mental health nurse, and that's different. You've got to be a mental health nurse for,
That's what, so if it's the GP, the nurse, and say a specialist or an allied health.
For non-mental health.
and for mental health, the nurse has to be a mental health professional.
It has to be a mental health nurse. Like a nurse can be in there, but they can't be recorded as one of the
So we've got-
contributors unless they're a mental health nurse.
So we've got a psychiatrist that wants to do case conferencing with our disability patients. So there's a psychiatrist, a GP. I wouldn't be able to be a third person if it's a mental health issue.
If it's a mental health.
If it's a mental health issue.
If it's a behavioural issue, same thing.
Yeah, that's a grey area because a behavioural issue isn't a chronic disease, it's a behavioural issue.
No, I mean, the people have got chronic, they're for disability patients, so ID patients, but yeah, so, because I sort of butt heads with my doctor about this, because I don't think that I can do certain ones.
Yeah, I think you're right, you
And
can't do all of them.
I pretty much said to her the other day, basically you're billing for it, so if you're taking responsibility, it's you paying back the money, not me.
Yeah.
So if you want me to sit there and do this, but I still don't feel comfortable with it.
Mm.
But I just wanted to, that was my big question for today.
I mean, you can be there because it can help with
Yeah,
planning, but
exactly.
you can't be recorded as an official.
Yeah, so mental health.
You need to be recorded. You need to be recorded as being there for the patient notes,
Yeah, it is.
but you can't be counted as one of the
No.
required.
For mental health.
Mental health.
But for.
Yeah.
That's
Is
okay.
there a different item number for teleconferencing though?
I think it's all the same
That's
now.
all the
It's all the
same.
same now. There used to be, but there's not anymore. So why do we bill chronic diseases? As I said earlier, these are the big ticket items. They're the big money things. These are where you want to maximise your skills, because they're the things that help keep you eating and keep the lights on. There's lots of information about business cases and developing business cases for these sorts of clinics, and if you want any more information, check on the APNA website. There's lots of links on there where to go. Mental health care plans, very quickly, need to be done by a doctor, can be supported by a practice nurse, but they need to be completed, and the care planning must be done by a GP. It's GP billing only. They can be supported, so you as a practice nurse can gather information and gather patient goals and do the assessments. The GP must sign off on the care plan, and they must do the care planning. Care plan review is pretty much the same. You can do assessment, you can do recommendations, you can do planning, you can do supporting. The GP must be involved, and it's only the GP time that can be billed. Cycles of care. There's lots of flow charts, and I'm more than happy to provide you with some outside of this if you'd like. The cycle of care must be completed within a time frame. There's only two components that can't be completed in the GP practice, and that's the pathology, because obviously that goes to the lab, and I don't think anyone has the facilities to do all of that in their general practice, and the formal eye check. So you must have a record of that formal eye check somewhere in your notes to be able to qualify. I really strongly recommend that when you're doing a diabetes cycle of care, you put it in the cycle of care part of your practice software. Use Best Practice Medical Director, ZMed, whatever it happens to be, to put it in the right spot, because it's much easier to find when you need the information. It's also easy to find when you're finding out who slipped through the cracks. There are complicated billing. Sorry, was there a question?
Does the patient have to be present for the cycle of care?
The patient has to be present to get all the parameters filled in, and then you can build the cycle of care. If the patient's not there, how can you check their feet?
Okay.
How can you check their blood pressure?
Can you bill for a 721 and a 723 and a cycle of care on the same day?
I don't believe so.
Yeah.
You can? You can. There you go. You can. Oh, there we go. So there's a little bit of money involved in that. For some practices, it's a substantial amount of money, and there was a little bit of fear running around the world with the impending changes to the PIP payments. Those PIP payment changes have been put off until next year, so the fear can simmer quite happily, and we not get too stressed until a week before it all happens next year.
What's the difference between like level B, C, and D?
Time.
So that's
Time. It's time-based.
Because we have some doctors here that use the 2525.
Yep. Yep, that's, if they've spent the time, they've spent the time.
It's just the time.
Really clearly marked out in MBS Online. Google MBS Online, click on it, put your item number in. Yeah. There's a cycle of care for asthma. 2 visits. One of them must be a planned visit. One way I did this in general practice was most children with asthma will need, or all children with asthma will need, an action plan when they go to school for the new year. And the schools like them updated every year. So I used to get them to come in January, a typical quiet time in general practice, for their planned visit, which meant we could claim our diabetes cycle of care for about 80% of our patients because they had a planned visit, and usually within the year they'd need a repeat script, or they'd have an exacerbation or something would happen throughout the year. So they'd have their unplanned visit, but they always had their planned visit. And it was one way I used to achieve that goal. Have a think about it. There might be other ways you guys can do it in your practice. And the asthma payment has less money, but still sometimes significant for a practice for meeting the asthma PIP and SIP guidelines. Any questions about asthma? Cool. So basically, involving all of your practice, involving your admin, involving your GPs and yourselves in chronic disease management makes a big difference to outcomes. Planning what you want to achieve. That diabetes cycle of care is really easy to adapt using the guidelines to a COPD cycle of care. That's just within your practice but can improve the outcomes for patients. We did, in one practice I worked in, we changed our practice to review all our COPD patients twice a year under the MBS guidelines. We decreased our hospitalisation rates by 3/4. We had 123 patients and reduced our hospitalisation by introducing action plans and stopping the one gentleman who sprinkled his Spiriva on his cereal, stopping him doing that and actually getting him to breathe it in. Because the review actually picked up these things. He'd been doing it for 3 years. So by reviewing him and reviewing the way, just under the COPD guidelines, reviewing his medication and the way he took his medication made a big impact in this gentleman's life, but also a big impact on the practice population because they were more well, but they were still coming into the practice. They just weren't coming in crisis, not breathing, which freaks everyone out. So planning your approach. Person-centred care is the most beneficial when you're doing chronic disease management. Having a continuity improves outcomes. Mental illness is a chronic disease. And you guys can do this really, really, really well. And I really believe that, so I put my money where my mouth is, and we've developed this, what we're calling our Care Coordinator Toolkit. Basically, it's about chronic disease management in general practice. There's some tips and hints that you might like to use, you might not, I'm not going to get offended, to help your chronic disease management for your patients in general practice. It's got some tools associated with it, like those things I held up, and that comes live on the SEMFEM website in next week. Also, if you want a copy before then, give me a yell and I'm more than happy to share with you. The only thing I ask, share it widely, do what you like, pull it apart, pull out pages. If you make a change to a template or to some of the things that are written in here, this is just my brain saying, this is what worked for me. Some other nurses and people have looked at it and have said, yeah, that makes sense. But if you see something that would help, if it's worded a bit differently, if it's changed a bit differently, please share it back because there's going to be other people who benefit from that. Don't reinvent the wheel. Someone did it. Use their brain and have a holiday. Thank you for listening to me. I'm more than happy to take questions or anything you like. Boo, hiss, whatever. Thanks heaps.